Next we have Dr. Stephen Little, who we all know. He's the director of our valve program and going to talk to us about 3D printing and structural heart interventions.
All right, so we'll do kind of a quick tour of what it means and how we're using it at Houston Methodist. So what is rapid prototyping, also known as 3D printing? Basically, it's the ability to create complicated structures, things like this shoe, for example, that have this sort of complex architecture of support, and to really make it out of a whole lot of different materials. So you can use plastics, which are most common. Depending on what kind of printer is used, you can use metals, ceramics. It's really amazing, even glass. So the materials that can be used by a 3D printer, this technology has just taken off in the last 10 years. So we don't print stilettos. We print something like this. This is one of the first versions we did. This is a life-size heart of a patient who had a cardiomyopathy. We just printed the ventricle in blue, or the left ventricle in blue, and the right side of structures in red, just as a teach tool, just to say, let's hold a heart. And every person we handed that to said, I cannot believe that's the size of the heart. But that's sort of that simple impact that can be gained from 3D printing. So let's take you through. How do we do it? Basically, you take a volumetric image. It can be CT, CMR, or a 3D echo. From that, you segment the parts you're interested in. So that basically means segment simply means you get rid of all the stuff you don't want to reproduce, typically the lungs, the ribs, the vessels you're not interested in. You get down to what you're actually interested in reproducing. In this case, it's a mitral valve. And you send this digital file to a printer, but you send it with some very specific instructions on what materials you use for what specific pieces. So that's sort of what the process is in one slide. Here's a quick poll of the audience. So at your institution, finish the sentence. So we use 3D printing to plan all complex heart procedures, plan for selected structural heart procedures as a research tool with very little clinical use, or really what the heck is 3D printing? So I've had hands up for all these options. Probably the best answer for places that have some experience in it is number 2. So select procedures. That tends to be the niche that it fills currently. So the 4 big applications for 3D printing are shown here. Anatomic teaching tools, I'll show you some more examples of that. Functional flow modeling, that's an increasing activity that we and other centers are getting involved in. Procedural planning, that's probably the biggest obvious impact for 3D print modeling. And then device innovation, particularly in structural heart, and knowing what the device will do in a particular patient before you put it in the patient is very impactful. So these are the steps of an actual 3D print. This is a CT with a zoom view of the aortic valve, shows the focal calcification. You can do some segmentation, really just identifying the ventricle, the ascending aorta, and the calcification, and the software within a CT data set is incredibly good at identifying calcium. Then you sort of segment out and say, well, which out of all those little elements, which ones do I actually want to reproduce? Then you sort of send that to a 3D print model, and there you go, and you can blend different materials. This is an example of part of how we do the quality control. This is an example of a CT of an aortic valve, so you're looking sort of down the gun barrel. You see the calcification in white and the non-calcified tissue in red. You can make a digital replication from that data. You can then print it, and then what you can do is you can CT the print. So you take the print and you put it onto the CT scanner, and that's what it looks like here. And then you can sort of measure the orifice. And did the process accurately replicate the valve area? And that's a measure. It's one of a simple sort of approach to quality control in these prints. So this is 8 different patients, and this is their ascending aorta and the aortic valve for several different patients with aortic stenosis, really just emphasizing some of the variability. The size of the aorta is slightly different, the shape is slightly different between every patient, the calcium patterns are slightly different, but also importantly, the actual shape of the flow orifice is slightly different. This one is sort of star-shaped, this one is more oval, and that has some implications in terms of how that valve area might perform under different flow conditions. Something that's a circle can't easily get bigger. Something that's star-shaped, if you force more flow through it, for example, on a dobutamine study, that orifice might actually be able to get a little bigger. So some early work we did was to take these 3D prints and put them in a heartbeat simulator, actually force flow through them. This is an example of what that might look like. So that's actually one of our patients. That's a patient-specific print of her ascending aorta, including the stenotic aortic valve, just put in the pulse duplicator. And you get that sense of pulsatility, and if you've been lucky enough to be in the OR and put your hands on a beating heart or a beating aorta, it has a very similar pulsatile quality. So we don't just pick random materials that look the right color. We actually put a lot of effort, and other centers are doing this now as well, to try to get materials that actually behave like cardiac tissue. So the simple tests are, we compress calcium to see does the 3D print material that's supposed to be calcium really behave like calcium? And the other thing is a tensile test. You pull material and think, does it break at a point when human cardiac tissue would also break? This is an example of a 3D print put in a flow loop. And on the left, we have the actual patient's echo. So this is a 2D echo looking at the calcified aortic valve. This is the spectral Doppler, the CW, through that severe stenosis. And this is the echo of the model. You can see the calcium's in the same place, and the ascending aorta looks very similar. But this is the interesting one. This is actually, if you replicate the flow volume, the stroke rate, you actually find out that the Doppler velocity profile looks very similar between the model and the patient. So that led us to say, well, we can actually replicate the function of aortic stenosis. So these are those same 8 patients now where we plot the valve area with different stroke volumes. So 8 different patients shown. Each one has a Gorlin equation, so the catheter-derived valve area as well as the echo-derived valve area. And you can see that for some patients, for example, number 4, there's no difference. The valve area is exactly the same no matter how much flow you put through that patient. Whereas this patient, number 7, there's a linear increase. The valve area actually gets bigger as you put more flow through. So that sort of gets back to the shape of the orifice probably matters, not just the actual area of the orifice. And that's sort of some new data from 3D printing of multiple patients. We've also, and others have experience in replicating aortic insufficiency. So this is a similar kind of presentation. This is the Doppler of AI, and this is the color flow of an actual patient. And this is their model put into a flow loop. And you can see you have a very similar looking spectral profile of aortic insufficiency and color Doppler representation of aortic insufficiency. So starting to take, you can take patient-specific anatomy. As long as you know the flow conditions, you can replicate them. And that gives you the ability to do things like this. You can actually do a tabletop TAVR. The idea being you take a patient-specific aorta, you can do a tabletop valve implantation at the same depth or the same height that either you want to achieve in the patient or that was achieved in the patient. And this is an example of actually replicating paravalvular leak. So across the top, again, we have the patient's PVL in long axis and in short axis. And when you put the same size TAVR device into the ascending aorta of that model of the patient, you see that you get the PVL in the same spot with the same function. So demonstrating that it's not a random thing, that the PVL is actually predictable based on the patient-specific morphology and the calcium location and the valve that you chose to put in. Turning to the mitral valve, this is just an example of sort of looking at creating mitral leaflets from 3D echo. So that's the raw data set. This is an example where we used a bilayer, sort of one hard material on the outside, a soft material on the inside, starting to demonstrate, and this is fairly early work, sort of the gross shape of a mitral leaflet. And then from this material, also sort of asking that question, well, the look isn't good enough, it has to behave ideally, at least in a soft, deformable way like real tissue does. If you want to actually do implantations with devices, you need the material to fight back the way a real tissue would in a person. So this is sort of some of the bending testing that we do, and this is a tensile stress test, and multiple different materials, just demonstrating that you can put different blends and test them and try to get close to the left bar and this bar here are the actual tissue samples. And these are 3D prints, sort of trying to get close to the physical properties of real tissue. This is some recently published work, again, where we looked at porcine or pig, anterior and posterior leaflet, a bunch of different material blends which look kind of not even close, unless you focus just on here, on the toe region, which is where the physiology really happens. This is more the pressure and strain rates in the body. Actually, the correlations are pretty good. So out here at the extremes, totally different behavior, but where it matters, the hemodynamic range, they're actually not too bad. So this is a patient. This is kind of why we do this stuff. This was a patient of ours from several years ago, presented to us basically inoperable. So this patient had a history of endocarditis, had a perforation of the posterior leaflet. You can see the flow is both through the middle of the posterior leaflet and through the coaptation zone, so 2 sites of severe MR. Severe pulmonary hypertension, refractory heart failure, exceedingly high operative risk. our excellent surgeon says, do we have another option? So we sort of combined what we have been doing with PVL plugging and mitral clipping and said, well, let's see if we can actually do a direct plug right through this perforation. It hadn't been done before. Not the time you want to practice on a patient, not knowing what size or what devices are going to work. So this is, well, we've done some 3D printing. Let's take that to the clinical realm and see if we can help this patient. So this is that patient's CT and echo combined in a digital model, in a printed model, and then finally creating a very specific left heart model to evaluate if we could offer this particular patient a solution. So this is a print of the left ventricle. This is looking down on the mitral valve. This perforation here in the posterior leaflet is shown in blue. The yellow stuff is actually where the calcium was, and this yellow actually looks like butter on the image, but this is actually subvalvular. This is on the undersurface or the ventricular surface of the mitral valve. So this is the challenge from below. So met with our device reps, said, you know, this is sort of a Goldilocks moment, what size was gonna fit, what's not, what's too big, what's too small. Finally said, well, this one is a reasonable looking device size based on the defect that we've identified. We put that device, a non-sterile version, through the defect, looked from above. It wasn't going to interfere with the coaptation zone. There's no cords in that area. Importantly, we looked from below where all the patient-specific calcium was and says, well, this is where the lumps and bumps are very unique to this particular patient. Will the device lay down flat? Is it reasonable that we think it's going to occlude this defect? And in fact, replicating calcium, laying that device down, it looked like it was going to do the job. Discussed with the patient, went to the procedure room, did a mitral clip first, put a plug through the posterior leaflet, and there's the final result. Claim to fame, this was submitted to JACC Interventions on a Thursday and accepted on a Monday. So fastest ever publication in my hands. And you know, you're staring at this for a long time with the hours of these things, and they take a long time. It was a 10-second slide, but it probably took a couple hours. And this was a joke. It sort of looked like this guy. And this dog actually has no name. It's just a never-ending story dog. But now, once you've seen it, you can't unsee it. All right, so this is sort of what we're doing now. That was a couple of years ago now. That was about leaflets. And others have taken this to the next step, looking at subvalvular apparatus. So this is now a CT depiction of the subvalvular apparatus, the cords of the mitral valve, sort of showing they're a little bit thicker than you might be in reality, but you're starting to identify all the cords. And Maria Vaskevic is in the room. She does a lot of this work now with Stefano. And they're sort of our in-house experts in this segmentation and anatomic identification. But this is kind of what we're getting to now. This is systole and diastole, again, focusing on the mitral apparatus all the way across, and you can see now the detail of the mitral valve depicted in systole and in diastole. You can even see the prolapse here of this particular scallop. So we're getting closer. And why are we getting closer? We're getting closer because we actually want to ultimately perfect individual procedures before we get into the procedure room. So this is an example of a mitral clip being deployed into a patient-specific, soft, deformable mitral valve. And you can see the clip is on, it's closing, it's actually approximating the leaflets. They're soft, they're distensible. It's clearly not pulsatile at this point. It's not set up in a flow loop, but at least to say, can we do a first approximation and grab tissue and make it do what we want it to do with a commercially available device? It was sort of a proof of concept that it can be done. The next step is to sort of make that even more complicated, to take the entire mitral apparatus, put it in a ventricle with an atria, and pulse flow. Try to actually replicate the patient's mitral regurgitation. Then you have a really nice test platform to practice specific procedures for that specific pathology to try to predict how many clips, what size clip, is clip even the right device? Maybe we should be using one of the newer devices that's coming along. So now we have the ability to sort of, or getting closer to the ability to test these things without being inside of a patient. This is another example of sort of creating, this is one of our first examples of creating MR. So there's the patient, continuous wave Doppler and the color. This is the model in a flow loop. So just like I've shown you before, the aortic stenosis and aortic regurgitation, now we're getting closer to replicating mitral regurgitation in patient-specific anatomy. And this is an example of, again, mitral clipping to get rid of this P2 flail on the benchtop. This was a very useful example from recently, the tricuspid, which you hear more about this weekend. Tricuspid interventions are very interesting at the moment. We're trying to adopt left-sided technology on the right side. And this is an example recently of a case, where you knew there's 3 scallops, they were well defined. You have a device, the mitral clip, that could put 2 of them together, but which 2 do you choose? You can't use a mitral clip to pull 3 leaflets together. So you have to make a choice. Is it the septal with the anterior with the posterior, or the posterior with the septal? Which ones are you going to try to grab? So this is an example where we did a 3D print, we replicated all the leaflets, and we tried different combinations of where do you put the clip to try to get the best result to bring these leaflets together. And this was the final result where we created this nice tissue bridge here. And it was one of our first, luckily, because it was very successful, and it kept us going. If it had been unsuccessful, we might have stopped. This was a case from just about a month ago. This was somebody presented at our valve conference, and this is the echo still image, and you can see there's some aortic stenosis, some calcification, there's some thickened mitral leaflets, but I must say the mitral annular calcification was a little underwhelming by echo. We just didn't see a ton of it. There was a little thickening, but hard to tell how much was calcium. This was the aortic valve printed from the CT, but importantly, this was the mitral valve. When we printed the calcium off the CT for this same patient, it was an entire ring of calcium, even going across trigone to trigone anteriorly. And when we looked from the side, there was this spicule of calcium coming all the way down the posterior wall. So much so that the surgeon completely changed the approach to this patient. This was not quite prohibitive. Well, this is probably prohibitive to remove the calcium in a surgical mitral valve replacement, so based largely on this model, the decision was made to put a sapien inside this calcium ring. So surgically implanted, take out the native leaflets, leave the calcium, put a sapien in with a couple of sutures to hold it there, and that's how this patient got a mitral valve replacement, without attempting to remove calcium. They ran all the way down into the posterior wall of the LV. So that's a very real-time and recent example of how we use some 3D printing. Where we're excited is in TMVR. You'll hear more about that this weekend. Transcatheter mitral valve replacements. Big concern there is putting in a big device, displacing the anterior leaflet into the LVOT and causing LVOT obstruction. One way to practice for that and to try to avoid it is to create models. So we've been doing that. This is a device implanted in a patient-specific model, and then a CT of that model to really demonstrate how big is the LVOT for this particular patient with this particular size device. So in summary, I think I'm at my time. Procedures with uncertain outcomes should be maximally planned. That's basically the premise. CT provides an unparalleled level of anatomic detail, especially for relatively static structures. The more they move, the harder it is to image. Patient-specific modeling is certainly possible now. You don't always have to do a physical model. You can do computational modeling, but at times 3D printing is required. And the notion here is that it gives you this idea to do bidirectional modeling, because if you have soft materials like are being developed, you can actually model the deformation of the material by the device and also how the material models the device. So they both change each other. And if you try to do this modeling into a rigid structure, you won't be able to capture that. So I'll stop there. Thank you.